So we're at ASCO, the tail end of ASCO 2016, and we're going to talk about just some of the highlights, some of the things that could potentially change the field, and some of the things that we still have a lot of open questions about. The first topic I'd like to cover is a presentation on a trial called JAlex, which was a Japanese study of a little over 200 patients who had an ALK rearrangement, so it's 4 to 5% of the lung cancer population, non-small cell. These were patients who have an ALK rearrangement but had not been treated with an ALK inhibitor before. The standard of care historically as a first ALK inhibitor has been crizotinib or Xalkori, but the trial compared that to a newer agent called alectinib or Alecensa that is approved as a second-line agent after crizotinib. And the question was whether there's a real benefit to moving Alecensa as a first-line therapy. It looked at progression-free survival as the primary endpoint and showed a really significant benefit, at least statistically significant, and the question is whether that is clinically significant. What did you think of the trial, and do you think that's enough to change practice?
Jack, I thought that this particular study, JAlex, was one of the striking new findings that we learned at ASCO this year. The way that the trial was done, comparing Xalkori to Alecensa head-to-head in the Japanese patient population with over 200 patients in the trial, and clear demonstration of improvement in effectiveness for Alecensa over Xalkori means that we may have a new first-line option. I would say that the other feature is safety. The toxicity profile of Alecensa was considerably better than what you see with Xalkori. So on both counts, effectiveness and safety, this drug won out. Now, what would it take to make this drug our standard first-line drug in the US? I think it'll be good to see how the drug does in a Western patient population, and that particular trial in the Western population that was done very similar design as the JAlex has been completed. We're waiting for the results. So I would like to make sure that these kind of results hold up in the Western population before we start routinely prescribing to our first-line patients.
Isn't there a difference between the two drugs? One of them gets into the brain and the other doesn't, right?
Well, that's another, I would say there are 3 key points. One was the progression-free survival was substantially longer at more than 20 months median. We don't know because the median hasn't been reached, but the lower limit of what was statistically likely at all is over 20 months versus just over 10 months with Xalkori, which is not under its usual results. That's about where it usually would come in, we would expect. So it didn't underperform, but Alecensa did quite a bit better, and the toxicity was substantially different. That may be different between a Western and a Japanese population, and the efficacy perhaps too. And then the penetration into the brain and a remarkable difference in the rate of developing new brain metastases, which is a particular issue with ALK-positive disease. It happens to be a biology that is associated with a very high risk of brain metastases at diagnosis or later. Everett, what did you think of this question of, do you need to see the data in a Western population or can we extrapolate? I mean, we did not wait to extrapolate in the EGFR population from Japanese data, even with a different EGFR inhibitor of gefitinib. Yeah. We made Tarceva a standard of care based on Japanese data with 200 patients. So what do you think about that?
I think that's an excellent point, Jack. IPASS was really, to me, still the landmark trial that applied molecular diagnostics and our understanding of targets and advanced the field to where there was no way back after that.
What was the IPASS trial?
IPASS looked at a clinically selected large group of patients and randomized them to chemotherapy versus gefitinib. And okay. It was clinically selected, but patients were molecularly profiled. And that enabled them later to have really 2 groups of patients, each of which was randomized to either chemo or EGFR inhibition. And by virtue of having that, they were able to show that the drug works in those patients who have the mutation whereas it is actually detrimental to give first line if patients don't have the mutation. And to me, it's still a brilliant landmark trial from which trials like this have naturally emerged, because here there was no control group that doesn't have the mutation, right? So everybody now has the mutation. We've learned that. And then looking at this trial and seeing the curve, I agree with Rams and your interpretation. This is a really, really important study. Now, I think it's a little bit small. And I think that could be a weakness. I'm not so concerned about Western versus Asian populations when the mutation is the same, right? So I think that the biology would win over ethnicity in a broader sense. But it is a little bit of a small trial. There will be confirmatory data, and my guess is it will be the standard of the future. And a question that emerges out of that in my mind is what happens, if anything, with crizotinib?
Well, so the reality is we now are in a time without necessarily an approval, and certainly without the global ALEX trial, which is in a global and Western population to corroborate, which I agree it's likely to do. So the question is, what would you do if you have a patient and can give either one? You say small trial, but ROS1 is an is a target that is predicated on a few dozen patients. Janet has a ROS1 rearrangement and is a beneficiary of a treatment that is predicated on small numbers but big effects. And of course, crizotinib itself was approved based on a few dozen patients in a phase 1 trial. But I don't think most...
I'm in the ROS1 trial. We have 50, but
right.
yeah.
So, but the point is, if the effects are big, do we need large numbers? Is I guess a global, the general question.
The other issue, Jack, that comes into play is now you can give a patient Xalkori, and in 10 to 12 months when they progress, you have 2 or 3 effective options. So you could essentially provide patients with various sequencing of ALK inhibitors to extend their life. If we move Alecensa to the first line, when they progress, we need to think about what options are available. And that's where how long patients do well on these drugs is important. If you look at EGFR mutation positive disease, patients in Japan do longer than patients in the Western population.
That's true.
Even with chemotherapy, patients in the Japanese world have much longer survival. So if the median PFS in Japanese patients is 25 months with Alecensa, if it is same 20, 25 months in the Western population, I think automatically Alecensa would be a first-line drug. But if the Western studies show the data comes in the 15, 16-month ballpark, then you start wondering whether it's best to give in the first line or you give both drugs and extend the span of benefit for a longer period of time.
I wanted to add one other thing. In both the trial, the IPASS trial that you talked about, and in the JAlex trial, in both cases they were randomized, but the patients were getting drugs that were effective for their mutation. So many patients are afraid of clinical trials because they think they'll get randomized to placebo. There was no placebo.
Right. Good point.
That's a very good point.
So what you're asking is really important, and it's ultimately really a survival question, right? So we look at progression-free survival, but what we have not figured out, so maybe we will know what should come first, right? But what is the sequence, right? And how do you engage one drug after the others? And that is where the kind of work that Alice Shaw and some others have done is so important, right? It says get a repeat biopsy, study the pattern, the cause that is underlying the progression of disease, and then try to again do something that is targeted.
Mm-hmm. Well, I think another huge question is we have other ALK inhibitors coming out that have a lot of promise and activity, and the question is where are they going to fit into this increasingly confusing, crowded field? Personally, I think it's worth underscoring, even if the survival comes out as a lateral move, the same, there could be a real benefit. There is an arguable big benefit in the toxicity profile being more favorable and control over intracranial disease being substantially greater in that 10, 11, 12-month period on Xalkori. But We'll see. There's going to be more data coming out.
Well, at least from a patient perspective, I don't know the statistics, but a lot of patients end up leaving Xalkori because they do progress in the brain. So if they could avoid that and have a longer period, the quality of life is going to be a lot better because we all want to avoid the brain radiation if we can.
And I think
That's
the
very
good
cool.
news is we have now many ALK inhibitors, and we have things to pick and choose from based on side effects, based on schedule and so forth. So this is good news for everybody.
Well, I think that the dream would be to be able to identify which particular mutations could lead to a good choice for a subsequent one, knowing that a drug like brigatinib or another one that we were learning about called lorlatinib that seems to have impressive activity in pre-treated patients could be a big advantage. So others coming out, we just need to figure out how to use them intelligently.